Hey, it's Jessica DaMassa with WTF Health. I'm here at Webit in Sofia, Bulgaria, and joining me right now, I have Vishal Nangalia. He is the founder of Aloo Ai. Ooh, so tell me about ELU. What is it? What are you guys doing?
So Aloo Ai, it came from a problem I experienced in hospital, which turns out to be massive, of deteriorating patients.
Okay. Deteriorating how?
So deteriorating as in getting complications, either dying in hospital, having a cardiac arrest, emergency surgery, anything unexpected that happens in hospital that is bad effectively.
Okay.
And what used to happen is, as an anesthesiologist and an intensivist, I'd get called to see the sickest patients, and almost every single time it was, why didn't you call me yesterday? Why didn't you call me this morning? And because I used to work in space medicine, whereby we used to do risk modeling on astronauts, going, should we be taking the teeth out of all astronauts before we send them to Mars or the moon? And we don't do that.
I was going to say, oh my God.
but there have been discussions about that, because there's a tiny chance of someone getting a cavity that could cause this problem. But we don't do that for normal patients. So I try to bring that thinking and my know-how in that field into my normal medicine. So what we do is we look at existing blood results, which most people have done when they come into hospital, analyze it in unique ways using AI, and find these tiny patterns that tell us what's going to happen to the patient in the future.
Okay.
So it's kind of based on algorithmic trading, if people know that, which is they take these data feeds of stock prices, Twitter, news, and then tell you, is the stock price going to go up or down?
Right.
We do that, but for patients, whereby we take their blood result feed, the time they came in, what drugs they're on, and feed that all into a real-time, engine, and it tells us the trajectory of each patient.
Okay.
And at the moment, if one of those patients we kind of think, ooh, they're going to do really badly or develop a complication, we kind of identify that and let the doctor or nurse know. To be honest, medicine's been doing this forever, but we just do it very, very, I won't use the word badly, but we do it
haphazardly?
Limited. I mean,
Okay.
doctors are good at medicine. They're not good at statistics, AI, technology, risk modeling, all of that. So
Okay, so
combine those two together and you suddenly have a paradigm shift.
totally. So I have so many questions about the algorithm that you've built.
Yeah.
How accurate is it? Like, by taking those data points and inputting them in, right? How likely are you able to or how close are you able to predict how likely someone is going to have an adverse event?
So I'll give you an example of one specific one. We've done it on tons of ones, but the ones we're most validated and advanced on is something called acute kidney injury.
Okay.
So it's massive, and it's basically a condition that means your kidneys aren't working very well. So acute, as in it's happened recently, it's your kidney, part of your body, and an injury as in something's happened to it, so it's not working. So kind of simple.
I got the kidney and injury
But
part.
it's kind of like it's a hashboard of all these other conditions that this is like an umbrella term.
Okay.
So we've got an algorithm, the world's got an algorithm for it. It's called the KDIGO acute kidney injury algorithm, and they take one variable, and 20% of all patients, so 100 patients get admitted to hospital, 20 of them will develop acute kidney injury. Either they brought it in with them or they get it in hospital. Of those 20%, about 10 to 20%, so let's say 10 develop it. Of those 10, 2 of them will die in hospital because of this condition.
Okay.
What the current algorithm does, it only identifies 16%. So 100 patients died with acute kidney injury. The AKI3 algorithm will identify 16% of those patients at a 1 in 3 level. And that's our gold standard at the moment. And when it identifies it, it says, get a senior nurse, get a kidney specialist to go see them.
Okay.
What we've done is, rather than change the entire structure, 100 patients die with acute kidney injury. We identify 95 of them using the same data streams. It's automatic, it sits in the background, and the only difference the doctor or the nurse notices is, 1, we tell you sooner, and 2, instead of identifying 16, we identify 95 out of the 100.
How are you getting the data inputs for this? Is this something somebody's entering in, or is this happening ambiently, or are you collecting it off of how are you getting this data?
It's 2 stages. We built the algorithm on historic data, 1 billion blood results from 20 hospitals going back almost 12 to 14 years in some cases. So a massive data set, all anonymized, done ethically, thing that way. blood results, what's beautiful about blood results is most blood results, no one's looking down a microscope and counting the number of cells or anymore. It's been done electronically for the last 15, 20 years. And it's done electronically by a big lab system. And that sends it electronically to a database that sends it somewhere else and in some cases gets printed out or goes to an EMR. We just sit in that data flow. So it already exists. So there's nothing new required. In fact, in the world of cloud computing, you can point a copy of that data feed to us and we'll do everything in the background and just point the result back to you.
Okay. How does the result get pointed back?
So that is an interesting concept. We started off, and when I say we, everyone starts off with, I'm going to build a new app for this.
I'm hoping it's not an app.
No.
Okay, good.
And it's because, you know what? Doctors, nurses, they don't want an app for kidney disease, lung disease, a fall. And that's what we're getting to. But we're starting with messaging platforms. Everyone uses WhatsApp, and you're getting secure ones for the NHS, for other countries. In Israel, they've got secure messaging to patients. And we're going, why don't we just use that? Why don't we behave like a geeky resident doctor? So this AI is like, you're the boss, you're the professor or the senior attending, and you've got a resident who's really, really good at this one thing.
Yeah.
And that's what we want to behave as. So the resident goes, Jessica, I think patient number 3, it's not doing that well. And that's what we do. We kind of communicate in messaging, going, hey, we think they're not doing very well because of this, this, and this. And if you see them and they're right, and I'm right, you're like, great, we fix them. If I'm wrong, we know I'm wrong because you don't do something or anything, and I learn from it. So it's like training a resident.
So how often are you right?
So the
It
gold
varies,
standard,
right?
well, it varies on the patient and different specialties, but the gold standard, remember I said the 16 out of 100, they are right 1 in 3 times.
Okay.
And that is the threshold that hospitals and clinicians have chosen to be raise a red flag to go and see. I mean, I know it seems absurd when you're a normal person going, hold on a second, you're saying if there's a 1 in 5 chance we don't raise a red flag? Right. There's reasons for it and stuff. But 1 in 3 was the threshold chosen. Okay. So we said, okay, at that 1 in 3 threshold, what do we want? Okay, we can do 95 out of 100 in the 1 in 3 threshold. Okay. If you want a 1 in 2 threshold, we'll capture 75 out of the 100. If you want a 1 in 1 threshold, we'll probably capture about 30 or 40 out of the 100. But all of them are still better than the 16 out of 100.
Okay,
Just
I'm following.
One example of one condition that we're doing.
All right, so I wanted to ask about the business side of this, and you led me beautifully to it by saying the one condition. So are you scaling this to other conditions? What's the vision moving forward for ELU?
We want to, so this has been validated on data. And it's been validated on a lot of data in separate hospitals and things. But we haven't actually said, as in you're the doctor, I haven't informed you, you've gone and seen the patient and changed their treatment. Okay. Now it's obvious because other studies where we've informed, not we, tons of people have informed, have affected their treatment. So what we're doing now is we're going to start a clinical validation of this system where we're going to inform the doctors and nurses about these patients and track what they do and see if it makes a difference. We know we don't do it, but we have to do it properly, independently, so they get involved, they do it, I don't influence it and things. So that's the first thing. Okay. Once you're in the system and people start trusting you, so now, let's say I'm ELU and I'm your geeky resident, and I've told you about the kidney injury patient, you'll tell your colleagues, you know what, ELU's pretty good at the kidney injury patients. But so tomorrow it suddenly goes, that patient who had a knee op, they're not moving as much, or their bloods are showing something a little bit off. Maybe you should see them or call them in, or don't keep them in hospital an extra day. So
you're proving the first case out, and then you're going to expand from there.
Exactly.
Okay, and then where are you guys at from how are you funded at this point now?
We raised over about 650K pounds. Mixture of grant funding and convertible notes. We've been part of accelerator programs, and we're now doing a £2 million pound raise as a seed, and that's so that we've got a working proof of concept. But this is medicine.
Yeah.
It's regulated, and safety has to be number one.
Absolutely.
So we need to redo the software so it fits in with all the ISO, so software standard certifications.
Sure.
We need to go through a clinical validation process. We need to have all the privacy and governance constraints. And we can't do it and say, yep, I've done it, it's fine.
No,
I need to do it and then hire a very expensive external agencies to come and try and break it and make sure, and they go, yes, it does what it says we're going to do. So that's what we're at the moment, and we're having pretty good traction with some VCs and funds in the UK, and hopefully in the next month or so we'll have closed the deal.
Awesome. Well, Vishal, great. What an interesting concept. We'll have to keep tabs on you and figure out how this goes. So thank you so much for joining us, and best of luck with your raise. Thank you. I'm Jessica DaMassa with WTF Health. Thanks so much for listening.